So our last speaker of the day, Wendy Ho, is another one of our faculty members who practices at Westwood, and she's going to be discussing the very important topic of colorectal cancer screening.
So I'll be talking about colorectal cancer screening today, and we'll briefly touch on the epidemiology, the pathophysiology of colorectal cancer, the goals for colorectal cancer screening and why it's important. There are many different methods, as you know, for colorectal cancer screening, and that makes shared decision making between the provider and the patients very, very time consuming. And so I hope to give you guys a framework from which you can work on that today. And we'll also talk about colorectal cancer screening in some special populations: patients with a family history of colorectal cancer, patients who are over 70 years old, and in Black patients. So colorectal cancer is a common and lethal disease. It's the second most common cancer in women and the third most common in men. In the US, it's actually the second most common cause of cancer death. And 1 in 3 patients who are diagnosed with colorectal cancer actually die from it. But it's a very preventable and treatable cancer, and screening can actually prevent deaths, while earlier diagnosis saves lives. So colorectal cancer, if it's diagnosed while it's localized, the 5-year survival is actually really good. It's 90%. However, if you have regional disease, it drops to 68%, and if there are distant metastases at diagnosis, the 5-year survival is only 10%. So let's shift gears a little bit and talk about how colorectal cancer develops, because this has implications in how we screen for and prevent colorectal cancer. So this is an adenoma carcinoma sequence. Normal mucosa here turns into hyperproliferative epithelium, which turns into adenomatous tissue. This is precancerous, which can turn into carcinoma if it's left in the colon over a long period of time. Adenomas are very common in adults over the age of 50, and so that's why routinely in patients without a family history of colorectal cancer, we start screening at age 50. These adenomas make up about 50 to 66% of all colon polyps, but less than 5% of them progress to cancer. It does take about 7 to 10 years for an adenoma to develop into cancer. However, 60% of colorectal cancers arise from this adenoma carcinoma sequence. Another pathway through which colon polyps can turn into colorectal cancer is through the serrated polyp pathway. So this accounts for about 35% of colorectal cancers. And normal colon mucosa in this pathway turns into a hyperplastic polyp, which turns into a serrated adenoma, which is precancerous, and that can turn into a carcinoma with varying levels of microsatellite instability depending on where it's located in the colon. These sessile serrated adenomas are more common in the proximal colon, and they're difficult to diagnose. They're flatter, and they're often covered with mucus. So I did a screening colonoscopy in an average risk patient, and so here's the polyp. You can hardly make it out. The borders are very indistinct. So I injected methylene blue into it, and you can see it a little bit better here. And this polyp was subsequently removed by snare polypectomy. So to summarize, adenomas and sessile serrated adenomas are precursors for colorectal cancer, and their removal can prevent colorectal cancer. So what are the methods for colorectal cancer screening? This is a table that summarizes the recommendations from the joint guideline from the American Cancer Society, the U.S. Multitask Force on Colorectal Cancer, and the American College of Radiology. And so you can break it down into basically 2 sets of tests. The first are structural tests that detect polyps and cancer, and that evaluate the whole colon. So those include colonoscopy, flexible sigmoidoscopy, double contrast barium enema, and CT colonography. And then the latter are stool tests that primarily detect cancer. And those include fecal occult blood test, fecal immunochemical tests, and stool DNA test. So let's talk about the flexible sigmoidoscopy first. This examines the lower half of the colon. So this is a colon here, and half of it is being examined with a flexible sigmoidoscopy. So it looks at the rectum, the sigmoid colon, and the descending colon here. Patients have to undergo a partial bowel prep. Sedation is not typically used, so they may have discomfort during the procedure. There is a risk of perforation, but it's very low. It's less than 1 in 20,000. And if any adenomas are found, then patients need to have a colonoscopy. So how good is flexible sigmoidoscopy at decreasing colorectal cancer incidence? So there was this one randomized controlled trial that looked at about 170,000 patients from the UK. 1/3 were randomized to once only flexible sigmoidoscopy with follow-up colonoscopy only if there were positive findings at the FlexSig. 2/3 of the patients were randomized to the control group, so those patients were not offered screening. And in the end, what they found was that flexible sigmoidoscopy does decrease colorectal cancer incidence and mortality. So it decreased colorectal cancer incidence by 23%, decreased colorectal cancer mortality by 31%. The number needed to treat to prevent one colorectal cancer diagnosis was 191 patients, and the number needed to treat to prevent one colorectal cancer death was 489. So we know that flexible sigmoidoscopy decreases the colorectal cancer incidence, but how good is it at doing that? So with flexible sigmoidoscopy, you're looking at half the colon. And so the implications are that if you see colon polyps in this half of the colon, you're more likely to see colon polyps in the other half. And that's true. But is the flip side true that if you don't have colon polyps in the lower half of the colon, does it then mean that you also do not have any colon polyps in the other half? So let's look at the data. So 2 studies were done in year 2000, which found that actually 50 to 60% of proximal colon lesions would actually be missed with flexible sigmoidoscopy. And so that's really important. So flexible sigmoidoscopy misses some proximal colon lesions. And so Dr. Daniel Podolsky, who was the chief of gastroenterology at Massachusetts General Hospital when I was a GI fellow there, he summed it up nicely by saying, relying on flexible sigmoidoscopy is as clinically logical as performing mammography of one breast to screen women for breast cancer. It is time to go the distance. So let's move on to colonoscopy. This is the most commonly used screening test. The whole colon is examined, adenomas are removed, and suspicious large lesions are biopsied. Patients do require a complete bowel preparation, and conscious sedation is offered. So patients typically have to miss 1 day of work, and they do need a chaperone for the ride home. Here are some examples of things that are found at colonoscopy. So here and here, these are tubular adenomas. And on the other side, here is an invasive colorectal cancer that was found in an elderly woman who presented with anemia. So how good is colonoscopy at reducing the incidence of colorectal cancer? In 1993, it was shown that the removal of colon adenomas actually reduces the incidence of colorectal cancer. But does this mean that it can also translate into decreased mortality? So using the same group of patients, they followed them over 16 years. And in this other study that was published in 2012 through the National Polyp Study, what they found was that colonoscopy with the removal of colon adenomas can actually prevent death from colorectal cancer. So that was really important because that was the first study to show that colonoscopy can lead to a colorectal cancer mortality benefit. Colonoscopy does have some risk, however. There's an overall complication rate of about 2.8 per 1,000 screening colonoscopy. There's a risk of perforation and bleeding post-polypectomy. There's also complication for conscious sedation because patients need to be sedated, and that's the most common complication. There's also a miss rate. So colonoscopy is not perfect, and in a study of 6 studies, looking at 465 patients, so a tandem colonoscopy, so one colonoscopy right after another, what they found was that there was a 2.1% miss rate for large adenomas, a 13% miss rate for medium-sized adenomas, and a 26% miss rate for small adenomas. So how often should patients get colonoscopy? So if their baseline colonoscopy shows no polyps, they get it every 10 years. If they have hyperplastic polyps, same thing. If they have 1 to 2 small adenomas, usually 5 years, 5 to 10 is what's recommended. If they have 3 to 10 adenomas, it's 3 years. Similar screening intervals for serrated polyps. So what if your patients don't want to undergo an invasive procedure like a flexig or a colonoscopy? There are 2 other options that evaluate the whole colon, and those include a double contrast barium enema and a CT colonography. So let's talk about the double contrast barium enema first. In this test, barium coats a colon mucosa and air distends a lumen. Multiple x-rays are then taken with the patient in different positions, and patients do need a complete bowel prep. So in these pictures, here's a carcinoma that's in the cecum, corresponds to this. Here's a polyp that's found in the colon, and here's an apple core lesion that's found in the colon. So if patients have 1 or more polyps that are greater than 6 millimeters, colonoscopy is then recommended. And if same-day colonoscopy is not available, the patients may need a second bowel preparation. The sensitivity for colorectal cancer is about 80 to 90%, but there are no randomized controlled trials that evaluate the efficacy of this study. And the risks include radiation exposure, and there are rare cases of perforation that have been reported. The other test is CT colonography. In this test, CT images are used to reconstruct 2D and 3D images of the colon. It has a pretty good sensitivity and specificity. In these pictures, here's a reconstruction of the colon from the CT colonography. Here's a 3D image of a polyp that's actually in the cecum. Here's a 2D image that corresponds to the same polyp. And finally, here is the actual polyp seen at optical colonoscopy. In both images here, you can see that this is the appendiceal orifice. So these are pretty good pictures. For patients to get a CT colonography, they do need a complete bowel preparation, however. And sometimes oral contrast is used. And the oral contrast actually can tag residual stool and liquid so that the radiologist can differentiate stool from polyps. And if your patients have any polyps that are greater than or equal to 6 millimeters, a colonoscopy is recommended. And again, if same-day colonoscopy is not available, then they may need a second bowel preparation. And it's important for patients to understand that if they undergo either barium enema or the CT colonography, that if same-day colonoscopy is not available, they may need to do a second colon prep and come in on another day. There are some risks of CT colonography, and those include discomfort. There's a rectal tube that insufflates air into the colon, and no sedation is used, so patients do find it uncomfortable sometimes, and there is radiation exposure. So the other set of tests are stool tests that primarily detect cancer, and those include fecal occult blood tests, fecal immunochemical tests, and the stool DNA test. So let's move on to the fecal occult blood test. This detects blood in the stool through the pseudoperoxidase activity of heme and hemoglobin. We need 2 samples from each of 3 consecutive bowel movements at home, and 3 large prospective randomized controlled trials have found that fecal occult blood tests actually can detect cancers earlier than unscreened patients. There are some dietary restrictions, however, which can make it cumbersome. And so patients in general have to avoid aspirin and NSAIDs. They avoid red meat, poultry, and fish. You also have to avoid some fruits and vegetables because those may contain peroxidase, which can give you a false positive. And also they have to avoid vitamin C, which can give a false negative result. The sensitivity and specificity is also highly variable, dependent on the brand, the collection technique, the number of samples collected, and whether or not they're rehydrated. And again, if you have a positive fecal occult blood test, colonoscopy is the next step. The newer test is a fecal immunochemical test. This detects only human globin, and so it does not detect upper GI bleeding because the globin is digested in transit. Patients don't have the cumbersome dietary restrictions because it only detects human globin, so even if they ate rare beef the day before, that would be fine. And it also doesn't detect foods with peroxidase activity, so again, they don't have to avoid those fruits and vegetables. The FIT test is also less demanding than fecal occult blood testing. It only requires 1 or 2 samples versus 3 samples with fecal occult blood tests. And there's no need to restrict the diet or to stop medications. There's also automated analysis versus fecal occult blood tests, which requires personnel to actually process it. But the sensitivity decreases with delay in mailing and processing due to hemoglobin degradation, so that can be an issue. And it's also a little bit more expensive than fecal occult blood testing. Regarding performance of fecal occult blood test versus FIT, there's no clear pattern of superior performance for either. But overall, FIT is easier for patients. And again, if you have a FIT, you do need a colonoscopy. A newer test is a stool DNA test. This actually identifies DNA markers in the colorectal adenoma and cancer cells. And these cells are continuously shed into the stool. The DNA is actually stable in stool, and it can be differentiated from and isolated from bacterial DNA. So the Cologuard by Exact Sciences is covered for all Medicare patients as of last month. It's approved for once every 3 years for asymptomatic average risk patients ages 50 to 85. It's a multi-target stool DNA test, and it also includes a FIT test along with it. So how good is this stool DNA test? There was one study that looked at 9,900 patients at average risk for colorectal cancer who were scheduled for colonoscopy. The enrollment was weighted towards patients over 65 in order to increase the prevalence of cancer. And they did a stool sample that tested FIT and a multi-target stool DNA, and these patients all had colonoscopies within 90 days of the stool sample. What they found was that 65 patients had colorectal cancer, and 757 had advanced adenomas or sessile serrated polyps greater than 1 centimeter. And the results were that the multi-target stool DNA was more sensitive than FIT for both distal advanced precancerous lesions and larger lesions. Their number needed to treat was about 166 for colorectal cancer, so it was better than FIT, but not quite as good as colonoscopy. So there are some limitations, obviously, of the stool DNA test, and one limitation is that their panel of markers cannot detect all colorectal cancers. So with this test, some colorectal cancers will be missed. If you have a positive stool DNA test, of course, that necessitates a colonoscopy. And there's also an unclear rescreening interval after a negative test. Medicare is currently covering it for every 3 years, but the actual perfect rescreening interval is yet to be determined. The costs of tests are important as well when patients are trying to decide which test to get. So here are the private pay costs of all of these tests compared to each other at one institution, assuming that the tests do not find any polyps or abnormalities that require further immediate evaluation. So over 10 years, colonoscopy and flexible sigmoidoscopy would be the most expensive tests, and fecal occult blood testing would be the cheapest. What about the cost effectiveness of these tests as compared to each other? So a review of 32 unique cost-effective models, over 55 publications, found that colorectal cancer screening is cost-effective and it is cost-saving as compared to no screening. But these studies couldn't agree on which test is most effective due to different assumptions that they put into the models and due to input of different test sensitivities. They do, however, agree that the newer technologies are not yet cost-effective, and those include CT colonography and stool DNA. Looking into the future, there is a colon capsule endoscopy. It was approved by the FDA earlier this year for patients who have incomplete colonoscopies. So this is a capsule very similar to the small bowel capsule that was previously discussed. It's a size of a vitamin pill, 2 cameras, one at either end. They take 35 pictures per second, and once it's swallowed, it takes 10 hours of photos, and it costs about $500. The sensitivity for polyps is about 85%. Specificity ranges between 60 to 95. The advantage is that it's non-invasive, no sedation, and no insufflation of air is required. And However, it does have disadvantages in that it requires a more aggressive bowel preparation than colonoscopy, because your colon has to be really clean, and with colonoscopy, you can sort of go in there and clean up a little bit, but with capsule, that's not possible. And there is a risk of capsule retention and aspiration. So let's move on to a question. So here's a 42-year-old woman, no significant past medical history, who has a family history of colon cancer. Her mother was diagnosed with colon cancer at age 80. So when should she start colorectal cancer screening? And how often? 1, colonoscopy at age 40, repeat every 5 years. 2, colonoscopy age 50, repeat every 5 years. 3, any form of colon cancer screening, age 40, and then repeat at intervals recommended for average risk individuals. And 4, any form of colorectal cancer screening at age 50, and then repeat at intervals recommended for average risk individuals. So it looks like the majority of patients chose number 4, any form of colon cancer screening age 50 and repeated intervals recommended for average risk individuals. So the recommendation is actually number 3. So any form of colon cancer screening at age 40. So you start 10 years earlier, but then you repeat at intervals that are recommended for average risk individuals. And so here are the full guidelines for patients who have a family history of colorectal cancer. So if there's a family history of colorectal cancer or adenomatous polyps in a first-degree relative who's young, less than 60 years of age, or 2 first-degree relatives at any age, you first start colonoscopy earlier, so either age 40 or 10 years before the youngest case in the immediate family, and you repeat colonoscopy at every 5 years. However, if the colorectal cancer or adenomatous polyp family history is in a first-degree relative who's older, so above age 60 years old, or in 2 second-degree relatives at any age, you start screening earlier at age 40, but then you can use any recommended form of the test, and you repeat at intervals recommended for average risk individuals. So what about patients age 70 and older? So in these patients, the decision to screen or not depends on the patient's health status, their anticipated life expectancy. If their life expectancy is less than 5 years, then they are unlikely to benefit from screening. You have to take into account their risk for colorectal cancer, whether or not they've had perhaps adenomatous polyps in the past, and you also have to take into account their personal preferences and values. There is a risk of adverse events that increase with age and that increases with comorbid conditions. So in a Medicare population, it was found that the GI adverse events increase with age, that the cardiovascular adverse events increase with age, and that patients who had comorbid conditions, they had increased risk of both GI and cardiovascular adverse events. So in this patient population, if one decides to screen, you may want to consider a non-invasive screening modality, such as CT colonography. In addition, please also take into account that flexible sigmoidoscopy has reduced sensitivity in patients over the age of 70 because advanced neoplasia is more likely to be in the proximal colon in these patients. In addition, at some point, colorectal cancer screening should be stopped altogether, and that should be whenever they have a life expectancy that's less than 10 years. In addition, the U.S. Preventive Service Task Force guidelines recommend against screening in patients who are over 85 and in patients who are between the ages of 76 and 85, unless there are individual considerations that favor screening. So let's move on to another question. Here is a 45-year-old Black man, no significant past medical history, no family history of colon cancer and adenomas, and he's wondering when he should start colorectal cancer screening. So 1 would be he should have started at age 40. 2 is now at age 45, and 3 is at age 50. So let's see, it looks like most people chose at age 50, but some people did choose now at age 45. So there are no firm guidelines regarding Black patients, but there is some data to suggest that perhaps Black people should start colorectal cancer screening a little bit earlier. And so in Black patients, there's a higher incidence of colorectal cancer, and in patients who are diagnosed with colorectal cancer, there is a higher mortality as compared to white patients. And this may be due to disparities in care, leading to lower screening rates, and that may be due to poor access to care, perhaps failure of healthcare professionals to recommend screening, and perhaps lower rates of participation when screening is offered. There may be some environmental factors and also some tumor biology. There is some evidence that suggests that disparities in care are responsible for this. It's known that non-white patients are less likely to be screened for colorectal cancer than white patients. There's also some difference in cancer prevention knowledge and behavior. In one study, Blacks scored lower on 3 out of 4 general health knowledge questions, and they were also less likely to believe that cancer is in fact preventable. There's also some data that Black patients have a different tumor biology as well. So Black patients have a higher risk of polyps that are big, that are greater than 9 millimeters. Also, in Black patients who are over the age of 60, they're more likely to have proximal polyps over greater than 9 millimeters as compared to white patients. They're also more likely to have microsatellite and stable colorectal cancers as compared to white patients. So all of this suggests that perhaps there's a different tumor biology going on. And so because of all of these factors, some are recommending that Black patients start earlier colorectal cancer screening at age 45. However, it's not a hard and fast rule. So to summarize, colorectal cancer is a preventable and treatable cancer. The goal of colorectal cancer screening is to prevent colon cancer by removing precursor lesions. Screening can and does prevent colon cancer deaths, and it is cost-effective. Colonoscopy is a preferred method because this examines a whole colon and it removes precursor lesions. There is some newer technology, including stool DNA and colon capsule endoscopy. If patients have a family history of colorectal cancer, we should start earlier screening at age 40. If their family members' colorectal cancer started at age 60 or younger, then their repeat interval is every 5 years. Otherwise, your repeated interval is recommended for average risk individuals. For patients who are over age 70, consider not screening patients who are over 75 unless they have a greater than 10-year life expectancy. And if you choose to screen patients who are over 75 years old or patients with comorbidities, consider a non-invasive method of screening, such as CT colonography. For Black patients, consider earlier screening at age 45. Thank you so much.